I am so honored to get to introduce Dr. Eric Pease. I've known Eric since 2009 when he was a senior in high school and was on the search committee that called me to First Presbyterian Church of Sterling. He said that there was only a 10-year warranty, so if you're all are unhappy at this point, it's too late to return me. Um, Eric was a very accomplished and active high school student. He was a swimmer. He was an Eagle Scout. He was active in the church and in all kinds of leadership roles in the community. Being a good Sterling guy, he went to Augustana College, of course. And that's where he met the love of his life, Allison, and they've been married for about 3 years. She's a veterinarian in Rochester. We've been so proud to watch him and his career. When he finished at Augustana, he started medical school at the Kansas City, I have this up on my phone because I had to get the names right, Kansas City University of Medicine and Biosciences. He was a neuroscience major at Augustana, and he is now a physician at Mayo Clinic with a particular emphasis and focus on child and adolescent psychiatry. And so I'm just thrilled that we could, because we're meeting via Zoom, we could have Eric come and talk to us. And I'm thrilled that he's now Dr. Pease. And it was kind of fun to do their wedding because it was Dr. Barry and Dr. Pease and Dr. Allison and Dr. Everybody. We just had to dispense with all our titles for a minute anyway. So without any further ado, here is our wonderful hometown guy, Eric Pease. He's going to talk some about the pandemic.
Thank you for having me. It's great to be here with you virtually. So as she said, I've been up here at Mayo for about 3 years now. Came from Kansas City after medical school.
Eric, can you keep your voice up a little bit?
Sure. Is this better?
Yes.
Okay. So I came up here to Mayo about 3 years ago after medical school and started training in general psychiatry, primarily treating adults. And then as I went on in my training, found that I thought that we could get more bang for our buck if we started earlier with this patient population. So that's what really drew me to the pediatric population. So now I'm in my final year of training as a child and adolescent psychiatrist. We are pretty busy kind of at baseline. So there's 8,300 child psychiatrists in the United States and about 15 million children who are estimated to need a child psychiatrist. So a significant discrepancy in availability based on, compared to the need. So we're typically pretty busy, and I would say that the last few months has really only made business boom for us. It's been hard, you know. Initially with the pandemic, things started out pretty great for kids because they got to be outside of school and it was kind of like summer. But children really crave a lot of structure and activity, and as those things have not come back as they've known, as this social distancing and lack of activity has persisted, kids and families are really starting to struggle with those changes. We're seeing a lot of families face some hardships, both financially and again, just with lack of structure, parents having to return to work and not a lot of plans of what to do with kids, and a lot of uncertainty around what school is going to look like in the fall. So we've had quite a demand for our services in terms of helping kids out who are really struggling. One of the things that we're also running into is just availability of resources. And I know this is something that you guys certainly face in rural areas, but even in larger areas, we have just not enough resources in terms of getting kids connected with therapy or case management, or regardless of whatever service it is that they need. Just a lack of availability or really extensive wait times kind of beyond what families can really manage with. So we're doing our best to keep things pieced together, but there's certainly been a lot of challenges that have come up with the pandemic. Trying to think what else would be helpful for you guys to know. So kind of what does a child psychiatrist do? I can kind of answer that. So, you know, a child psychiatrist plays a role in kids who are struggling in terms of kind of taking a step back and looking at the bigger picture to try to figure out diagnosis and make treatment recommendations. You know, as the physician, we bring some expertise in terms of, are there medical issues going on for these children? If so, is that impacting psychiatric symptoms? Likewise, is this person having a psychiatric illness that's impacting an underlying medical condition? So it's really the role that we bring. And then we also make a lot of recommendations in terms of types of therapy that would be helpful or services that would be helpful for families to navigate the challenges that they're facing. Typically, we see kids on our panels somewhere between monthly to every 3 months, depending how the child is doing. That's a little bit different than the role of a therapist who might be seeing a family once a week to once every 2 weeks. So we're not necessarily on the forefront, but we're trying to coordinate the services for our patients and kind of recognize all of the moving pieces that need to be put into place for patients' treatment to be successful. Child psychiatrists work in a variety of settings. This morning I was over in the ICU with a patient. We also work in the emergency department, and then of course see patients in the outpatient setting as well. The work is always variable. You never really know what you're going to walk into, but that's what also makes the work very exciting and very rewarding. So it's never a dull moment in the world of psychiatry, but especially in pediatrics. And I really enjoy the work that I do, and despite the challenges and resource availability, get to come every day and interact with children and families and try to figure out how we can be most helpful. So that's kind of what a psychiatrist does and some of the impact that we have seen. I'm happy to open things up. We kind of want it to be more of a discussion and answer any questions that you have in terms of the work that I do, or I'm happy to entertain any questions. Yeah, Dr. Helmick.
Could you talk about the decision-making process you went through as a kid in deciding to be a physician, and then the decision-making process in being a psychiatrist specifically?
Sure. When I went to medical school, I was pretty certain that I was going to be a family medicine doctor. Kind of saw myself, you know, going into this field where you take care of children and adults in all stages of their life with really a variety of different conditions. And as I went through medical school, that interest shifted, and I started realizing that I was drawn a lot to the patients that were frustrating for everyone else. Patients who were not necessarily compliant with treatment recommendations or didn't seem to follow through with things. And I would ask myself, why are these patients struggling? And I quickly realized that there was a lot of mental illness that was going unrecognized. So maybe this person didn't go pick up a medication from the pharmacy because they're depressed and they don't want to leave their house. Or maybe this is early dementia and the person actually doesn't understand any of the instructions that we asked them to follow through on. So we realized that, you know, if the mental health piece is not optimized, everything that we're asking patients to do is just not going to happen the way that we intend. So that's really what drew me into psychiatry in particular, is trying to get a better understanding of like really the patient's foundation for their overall health, right? So optimizing the mental health piece to be able to optimize their overall wellness. As I was in my training primarily with adults, I met a lot of people along the way, patients who really had struggled for a long time. And I thought to myself, what could we have done differently? Could we have changed things before they got to this point? And that's what drew me to the pediatric population in particular, is having that ability to intervene earlier and try to get things back on tracks. Because and not to throw my adult colleagues under the bus, but sometimes in adult psychiatry, we're chasing symptoms and trying to keep things pieced together as best as we can. But these are chronic illnesses, and it's just chasing symptom after symptom. Whereas in child psychiatry, we have a different outlook and are able to intervene earlier and potentially even stop an illness from becoming so severe later in life for someone. I still have a lot of respect for people who go into primary care and family medicine. It is an incredibly challenging field to go into. We expect a lot out of primary care. I'm very grateful that I'm in psychiatry. Every day is different. Every patient case is different. There's no two cases of depression that are the same or schizophrenia that are the same. So I like the variety and find the work very challenging, but also rewarding.
As a child, did you always know you wanted to be a physician?
I did not. So I kind of went through a phase of wanting to be a forensic scientist. I think it was influenced by the show CSI. And then, later, probably mid to late high school, I started thinking about medicine. I shadowed with Dr. Ayer in pediatrics, and then also with Dr. Steinke in family medicine. So I kind of went to college with the idea of being a doctor. But I would say probably late high school is when I started seriously thinking about that as a career.
Eric, did I hear you went to KCU?
Yes, I did. Yep.
So did you go to the Kansas City or the Joplin campus?
I went to the Kansas City campus. Yep. Yeah, Mr. Murray.
I got 3 quick questions.
Okay.
Can you address, we keep reading so much about the effect on particularly little kids of isolation during the pandemic. What do you say about that? And second, recognizing you're pretty young in your career, but are you making any effective change in these young kids that you think is going to pay off when they get older instead of getting worse? And third, tell us about how you got into Mayo Clinic.
Sure. So your first question, yeah, it's hard. One of the things that I constantly reinforce with my outpatients is that kids need to be in school. And right now that puts a child psychiatrist in a pretty tough position, right? Because I really don't know if school's the best place for kids to be right now from a public health standpoint. But school provides structure and a lot of socialization and a lot of developmentally appropriate interventions to keep kids on track. That being said, I think schools are getting really creative with how they're going to navigate things in the fall. And I don't think that there's a right or wrong answer for schools at this point, but yeah, you're right. Structure is critical to development, and all of the things that school provide are absolutely critical. I think that the best thing that we can do as big grown-ups for kids is to be supportive of whatever decisions are made and be enthusiastic, even if we're not sure that that's the right decision being made. But kids just need to know that we're here and supportive of them and want to see their development stay on track. I do think that early intervention helps. To get to your second question, teaching kids how to self-regulate, teaching parents how to help their children self-regulate, and also being very clear about, what is a medication going to fix? What is it not going to fix? Where does therapy come in? What role is that going to play in your family system? Is really what I do a lot of in my practice. I have parents who come and say, oh, we need a medication for this. And sometimes my role is to not prescribe, is to say, well, a medication's not going to fix that. But if we try this, this, and this, maybe those are the things that are going to be helpful. And I think that's the benefit of being a psychiatrist is, although I'm not seeing these kids week by week like a therapist might, I kind of get these snapshots, so I get a little bit of a bigger picture in time. to see, are we on track or do we need to rethink what's happening here? But I do see kids get better. Even kids who are on our inpatient unit get better, which is not always the case as disease progresses and gets more severe. And then as far as how I got into Mayo Clinic, when I was a medical student in your 4th year, you get some time to kind of pick and choose to go to different facilities and do rotations. And I applied to do a rotation here and spent about a month here doing a rotation on our consult service and on the inpatient unit for children. And I really found the people and the culture here at Mayo was a good fit for me. I liked the team-based approach. Mayo is certainly resource rich compared to a lot of other places. So there was a good balance between having time to do some research, time to learn, and also time to take care of patients. So that combination was a really good fit. And I was lucky enough that when the time came to apply, that they were willing to have me. Yeah.
How old is a child? Like up to 18? Is that what you see?
Yeah. So our cutoff is 18 and still in high school and
Okay.
under. Yep. So
Okay.
I think the youngest patient that I've ever seen was 13 months. And then I see patients, I try to sneak a few transitional age in there, like the 20 years old. I like that group.
Okay. Okay.
Yeah.
And then I didn't know if you were aware that CGH is building a behavioral health unit. So maybe someday down the line, and we don't need a child psychologist, hopefully, but maybe someday down the line, you'll be able to come back to
Yes,
the schooling area.
I did see that. I think that's great that you guys will have that resource.
Hopefully we won't have that need for you, but in our small community.
Yeah.
A question for you, Dr. Peter. 3 questions, actually. The first is, based on your current knowledge and your historical knowledge, what do you think of the general psychiatric health of children and adolescents today compared to, say, 30 or 40 years ago?
Yeah. 2 things. I think there's a lot more awareness. So I think that's why we're seeing an increase in need, right? Because we're identifying that in kids. The issues that I address have always been there. We're just starting to give more attention to them. But I've also noticed kind of a trend away from just this inherent ability to cope, right? Or tolerate distress. And we're kind of raising children in a society where there's a lot of things happen instantaneously, right? Like I can send an email and then you get it. I don't have to write you a letter and you have to wait to receive it. Or things are very rapid, and I think kids sometimes expect rapid responses when they're overwhelmed or upset.
How about the issue of the helicopter parents?
Yeah, I love helicopter parents. They are workable because they're always present. You know, you can coach a helicopter parent to increase their distance. I think absent parenting is really a greater challenge.
Okay, last question is, you know, I've read a lot in the news about people, some professionals that are pushing children who are even 8, 9, 10 years old to identify as somebody of the opposite sex. What have you seen or learned about that? What are your opinions about that?
Yeah. You know, I think with any form of identity, whether that's gender identity or professional identity, regardless of what stage you're in life, you have to make that decision. And sometimes as a child psychiatrist, that's me just sitting with uncertainty and helping a family sit with uncertainty. You know, just like it's not helpful to tell a child what they should be when they grow up or what sports they should participate in, what things we want them to become. kids really need to figure that out for themselves.
At what age do you think a child is actually competent and aware enough to decide what gender they want to identify as? And of course, each child will develop at a different time scale. But in general, what about what age do you think a child can self-identify?
I think it's probably when children gain the ability to have abstract thought, which would probably be somewhere between, excuse me, 11 and 12, right? Because otherwise, children are pretty concrete thinkers and have a kind of trouble thinking outside of the box a little bit. But when 11 and 12 sets in, they really start to kind of picture themselves in the world and recognizing that other pieces of the world impact them. So pretty young age, really.
All right, thank you.
Yeah. Yeah.
John, you're muted.
Yes, Doc, I have a question with regard to the impact of social media on adolescents. That's a relatively new phenomenon. And I don't know how old you are, but you're not that old. So I don't know if you grew up with it or not, or whether you can relate. I know 30, 40 years ago, the question was, I'm sure you weren't even born then, but how about this impact of social media on children, adolescents, and the psychiatry of that?
So I did not grow up with a ton of social media. I was coming into the scene late high school for me. But I have this love-hate relationship with social media. I think it's really positive in a way that it can bring kids together and keep kids connected, especially kids who are socially anxious, right? It can kind of give them a medium to interface with peers, especially in times like this where they're physically distanced from family or peers. They can keep in touch and kind of see what other people are up to. But the piece that's really difficult for kids is again, back to that instant gratification, right? Like, oh, I saw a picture of this person doing this and I can't do that. My life is terrible. It can quickly spiral out of control. There can be an amount of bullying on social media. I think a lot of things happen behind a keyboard that wouldn't necessarily happen face to face. And that can be really tough. I think social media is here to stay. So teaching kids how to navigate using it responsibly and using it for the positive aspects is probably what's the most helpful. But that requires some oversight on parents, but also some trust that the kid needs to demonstrate over time to be able to use it. But yeah, it's a double-edged sword for me in terms of social media.
I think that this pandemic has shown that we are social, humans are very social, and a lot of this socialization obviously develops as children develop, and interaction with peers, and as it happens in schools and so on. And I heard something where, it's difficult to send kids to school now and not expect them to interact with their peers, to kind of keep socially distanced. It's kind of hardwired to do that. And I think your point is well taken. There's social media substituting for face-to-face interactions with children. If you had to put the clock on, not the clock, but a meter on, would it be leaning towards social media being better or worse? I hate to put you on the spot, but I kind of like to know, as opposed to 50-50.
Yeah, that's a good question. I think it's probably for better, right? I do think there's a component of face-to-face social interaction that we just will never be able to substitute with social media. But I do think that there's a sense of community that comes with hey, I found these people who are similar to me, where there might not be as many of those kids at school. So kids who struggle to kind of integrate into certain groups of peers can find a lot of sense of community online. And as long as those are healthy relationships, I think that's a positive thing.
Thank you.
Yeah.
Eric, I think part of that question, to go a step further, is in your training platform up at Mayo's, are you dual trained in person-to-person and telemedicine? And is there a time when you think one is preferred over the other? And has social media kind of come to the level of acceptance where telemedicine can become very efficacious or just as efficacious?
Yeah, that's a great question. So my training in telemedicine before April was pretty minimal. And then my training in telemedicine became pretty in-depth in about 24 hours. So we were all given laptops and told this is how you're going to see your patients for right now. Now we're back to face-to-face, but offering telemedicine appointments. I have found personally that I don't mind telemedicine, but I prefer to do it for a patient that I've met in person. It's really hard, even as a psychiatrist, my physical exam is typically based on observing someone and their behavior. So I don't necessarily have to lay hands on a patient to examine them. But it's still really hard to do that through Zoom, right? I do think that it's a good platform to follow up with patients. The one thing I don't like telemedicine for is kids with anxiety, especially any social anxiety, because avoidance is the hallmark of anxiety. So if we are permitting them to avoid coming to an appointment, we're almost fueling the anxiety, right? It's good for kids to be able to challenge their fear and show up to an appointment face-to-face. So again, a double-edged sword, but I do think it's really helpful. And it also, there's not very many child psychiatrists. So if I can reach out to rural parts of Minnesota and prevent a family from having to take an entire day to come into Rochester and park in the parking garage and go through the COVID screening, come up 11 floors to my office, yeah, I would absolutely see that child through telemedicine because it takes me to them instead of them having to go through a lot of hoops to get to me.
Eric, I have a couple of questions. When I was a counselor in the field, I worked primarily with children and adolescents, and one of the things we used to tell parents were that we thought two of the most difficult factors for children and teenagers were disconfirmation or discouragement and isolation. And those were big factors that we saw in a child or a teenager's mental health. Do you think those are still germane today? And then the other thing I wanted to ask about is, are you seeing kids develop diagnosable difficulties because of things like internet bullying or those kinds of things, or are they simply exacerbating existing conditions? So those two things.
Sure, good questions. So isolation is, that's a good question. So isolating can be really concerning if you have a teenager, but it's also developmentally appropriate for a teenager to want some privacy and some time alone. So I think it's really paying attention to the trend of isolation, right? Is this person no longer doing the things that they used to? Are they not interacting with friends or family as much anymore? That would be much more concerning than, someone who wants to come home and have an hour to themselves every night to do whatever it is a teenager does when they isolate. So really kind of the trend of isolation, I would say, is what's there. In terms of the other, I would say kids need to know that adults and the system around them, whether that's a parent or a guardian, a teacher, a minister, whoever their people are, need to support them and be available, right? So kids do some weird things. They might say provocative things. We need to be available and sometimes neutral to their behaviors, but also for them to understand that we want to see them grow and figure out who they are, where they want to be. A lot of times with therapy patients in particular, I try to help kids understand, like, what are your values? What do you want to do when you're a grown up, when you're not living at mom and dad's house anymore? How do we get you there? So supporting that identity as it develops, and that can be a painful process to watch as a parent, right? But really important to nurture their growth in that way. And then in terms of the bullying leading to diagnoses, it's a good question. I like to think of stressors, well, psychiatric problems in general, as kind of an internal vulnerability with an external stressor. So I can't say that financial hardship is going to cause someone's depression, or that bullying caused someone to be anxious. I think that it's a lot more, there's a lot more pieces to the puzzle than that. But I certainly think that those factors, the stressors, exacerbate things and get in the way of those things getting better.
I have a question. So when you see majority of the children, do you find that they share more with you than they do the parents? Or I mean, sometimes I have teenagers, but I always wondered about that portion, you know, if they would share more with us, someone they really didn't know as well.
Sure. Depends on the kid, to be honest. Most kids are really pretty honest, and they kind of present themselves as they are, but there are certainly those that, you know, I've been seeing for a year and a half, and tell me something pretty big in their life, and it's like, oh, okay, that would have been helpful to know 18 months ago. I'm glad you shared it now, but yeah, it really depends. I don't have a good answer for that.
Do you find that there's a fear with the children more so, or more so the adults?
I think adults, yeah. Adults, we're afraid to be judged, or to have our baggage kind of categorized or diagnosed, right? And kids are kind of just like, this is me, and figuring out who I am, and they're a little bit more pure in that way.
Thank you.
Could you tell us a little bit about your wife, where she went to vet school, what kind of practice she has, and you all met in school? I mean, why did you fall in love with each other?
Sure. So I actually met her the day that I was registering for classes at Augustana. And we started as friends and didn't start dating until about halfway through college. When we graduated and I moved to Kansas City for med school, she moved to Champaign to go to University of Illinois for vet school. So we were apart the 4 years of med school and vet school, and then married the first fall of my residency. So a few years ago. She currently works at a small animal practice here in town. There's about 5 other veterinarians at her practice. They do exotics, dogs, cats, birds. And this is the second practice that she's worked at. The first practice was a little bit outside of Rochester, strictly dogs and cats, but she was the sole full-time person there. And I think just starting out in her career, kind of likes having a little bit more backup and more of a team approach. So she's at a bigger practice now and really likes it there.
What kind of exotic pets do you have?
I think this past week she saw an iguana. She saw a turtle that was
at your
37 years old. Oh, at our house, no. We just have 2 dogs and 2 cats. Recently acquired the second dog.
Okay.
Yeah.
And I just have a message for you. Dr. Steinke says hello. Sorry
Okay.
he couldn't make it. He's dealing with power outages, but he wants to Zoom with you soon. So I need your contact information for him.
Okay.
And I probably can get it from Christina, huh?
Sure.
Okay.
I have a question for all of us. I think that it would be helpful to hear your perspective on we're a service organization, service above self, and seek to benefit our community by the work we do. What are some things that you think a group like Rotary or individual Rotarians can do to further the mental health and well-being of the children and adolescents in our community?
Oh, that's a really good question.
And I know you know the answers. You have all the answers, Doctor.
I think that a lot of that comes from modeling in the work that you do, right? So teaching kids that it's important to give back to the community, and that why do Rotarians do what they do? We support the community because the community supports us, and really instilling that mindset. Maybe it's involving them in whatever event you're putting on, giving them a role and helping that event be successful, but demonstrating to them the importance of community. And we can be fortunate, but it's really important for us to give and be charitable, because the community depends on us, and we benefit from that.
Any other questions?
Eric, I had asked you earlier if you ever see Dr. Liz Yem up there at clinic. When and where do you interface with her, and do you see her very often?
Sure. I see her a lot less now that I've transitioned primarily to pediatrics, but we frequently share patients and kind of those overlaps between psychiatry and neurology. So either in the outpatient setting or even in the inpatient setting, if there's kind of a psychiatric component to one of her neurology patients, we frequently collaborate.
Just another plug, Dr. Yem is also from First Presbyterian Sterling. Just had to throw that in.
All right, any other questions? This was, I enjoyed it, Dr. Pease. Very, very good information. And like Dana says, since we don't have anyone in our area, that practices, it was very interesting. So thank you very much. And hopefully your mother got to join. What was that?
Thank you for having me.
Oh, you bet. Anytime. Yes, very good. Thank you.